It's 5 minutes after noon. Unless there are objections, why don't we start? Um, um, there's a message on the board that archive rounds are located in the site that's posted, and I'm assuming this will be available also. On behalf of the rehab team in the Central East and myself, I'm happy to present medical rounds today. I don't believe we presented as a team to grand rounds in perhaps 5 or 7 years. So I welcome the opportunity for us to be able to talk together. I've created a presentation which I'll highlight, summarizing the program um, and um, and the key features in terms of participation from our patients in the region. As I mentioned, I'm happy to interrupt to provide questions. If you have a question, please add them to the chat box. I don't have any specific disclosures. I was previously the medical director of the cardiac care program till 6 years ago, and I'm currently the medical director of the regional cardiac care program. I manage a secondary prevention service that's been in place for 20 years called the Cardiac Care Quality and Education Platform, and I have disclosures financially related only to my educational and quality of care projects and initiatives, which are listed here. My objective today is to provide an overview from a cardiovascular perspective about secondary prevention, talk about the regional program in terms of its history and where we are today. And then I'd like to focus then on the program itself, what actually cardiovascular rehabilitation involves and how the service is delivered in our community. And I'll close by providing information about how best to access the service for your own patients. Firstly, it's important to understand that cardiovascular rehabilitation is part of a secondary prevention strategy that's been endorsed in Canada for more than 3 decades, from the early 1990s with the first position paper of the what was the Cardiac Care Network Ontario and is now Core Health. This direction for secondary prevention and cardiovascular rehabilitation reflects the importance of secondary prevention in our outcomes. While I'm a cardiologist, and as you're all aware, we've made great advances in procedurals, including imaging and angioplasty and bypass surgery and electrophysiology. All of those services are critically important to our patients, but the majority of the value we provided to the health of our population is in fact related to all those measures and the research that's been done around secondary prevention. And that underpins almost everything we do in cardiology, whether it's coronary disease or dysrhythmic disease. All of those patients have underlying cardiovascular conditions for which their secondary preventive strategies are highly effective. In fact, over the past generation, the effectiveness of those strategies has reduced cardiovascular mortality worldwide by more than 50%. It was a reality in the 1980s that myocardial infarction mortality was in the range of 20%. That has declined currently to less than 4%. And even though we talked about gaps in therapy, more than 80% of our patients have a reduction in cardiovascular risk factors compared to historical controls. It's estimated by the Population Health Group in Hamilton that 50 to 60% of the improvement in these outcomes does not have to do with cardiac interventions and diagnoses, but due to advances in secondary preventive medical therapies, which we consider commonplace now, but which I'll show you have a huge effect on outcomes. Just to highlight this, in January of this year, in the Journal of Cardiology, the American Journal of Cardiology, JACC, there was a worldwide review of the epidemiology of cardiovascular death by Dr. Valentin Fuster that looked at cardiovascular mortality continent by continent and literally state by state around the world and published statistics which for Canada demonstrate what I'm showing you here. Remember, to get population statistics, there's a lag of 10 to 20 years, so we don't have the most current data. But just to highlight this, between 1991 and 2000, you can see the gray bars compared to the green bars. In every age group and for every gender, there was a significant reduction in cardiovascular mortality, even to 2001. I can promise you that the impact of this now is even greater than this data we have available to us. Why is that? It's because if patients have established cardiovascular disease and therefore need secondary prevention to prevent future cardiac events, the purpose of that therapy is to prevent vascular events that lead to symptoms or evidence on imaging for coronary disease, or unfortunately, events that lead to hospitalization like myocardial infarction or stroke. It's those complications and that development of documented ASCVD that leads to decline in quality of life and survival. And it's that impact of secondary prevention that's had such a huge impact on population health. In fact, to turn this around, if a blood pressure of 200 or a blood sugar of 50 had no effect on people's survival or quality of life, whether they could keep golfing, spend time with their grandkids when they're older, we wouldn't care. But it does matter because all of those risk factors that we now treat aggressively improve all those outcomes. And what I'd like to show you here, we talk now about pillars of care, because a pillar of care is something where the evidence is strong enough that they're actually now the standards of care, meaning every patient with ASCVD should have access to the therapies listed in the table on the right and shown in this diagram of a Roman structure. Because each of these therapies, lipid therapies, ACE inhibitors, exercise, dietitian, and more recently, things like colchicine and SGLT2 inhibitors, each independently reduce cardiovascular risk by as much as 20, 25%. And it's been estimated that the combined effect of this accounts for most of the benefit we see and could reduce risk by as much as 85%. This is important for two reasons. That effect is large, but secondly, we've learned that earlier therapy, so time under treatment, the longer a person with ASCVD receives therapy from the time of first diagnosis, the greater the benefit. Because as these curves show you, for all of these therapies, the benefits are identifiable in 2 to 3 years, but the benefits start early and they widen over time. So the message for all of us here is that prevention and cardiovascular rehabilitation is both something we should start early and a lifelong strategy, which means that we have to reframe our perspective on most cardiovascular disease related to ASCVD and heart failure, and stop looking at it about something as something we need to deal with once person has a heart attack or has heart failure admitted, because we're at the end, the late stage of that disease when we wait to that point. What we need to do is reframe this as a chronic condition that requires early diagnosis, early second prevention therapy to prevent the late progression that we focus on. And I would argue that it's a mistake to focus on heart failure patients who are admitted when 3 times or 4 times that number of patients are in our community with reduced ejection fraction and deserve aggressive medical therapy, or have coronary disease documented and testing and may not have a heart attack yet, but deserve the best therapy we can provide earlier. And like, while people talk about the Canadian healthcare system and some of its gaps, and there are gaps related to economic disparity, lack of primary care physicians, lack of resources, finances, all those gaps are real for patients and for us. I'd like to show you what was published in January. This review by Valentine Fuster worldwide showed for every country in the world a mortality map for cardiovascular disease. And this data is detailed. So for North America, I'm showing you here that documents summary for North American cardiovascular mortality for every province, every territory, and every state in Canada and the United States. And what I'd like to point out to you is, although I spelled Canada wrong, is that every province and every territory in Canada has a lower cardiovascular mortality than every state in the United States of America, despite differences in our healthcare system, despite the amount of money spent, despite the number of physicians. And admittedly, Americans may be different than Canadians. They have a different genetic pool. They're more overweight. They're less active. They sadly still smoke a fair bit. They drink too much. All of those things are true, but this, I think, is also a reflection of our quality of care and a long focus on secondary prevention in Canada. So against that background, I'd like to talk to you about cardiovascular rehab in Ontario and in our region particularly, and what it's about and why it's so important. It's probably best if I start with a case. So I'd like to highlight this by describing an actual case of a person who had a heart attack around 1990, who at that time called an ambulance, had his wife drive him to hospital, presented to the emergency department, was admitted to hospital and spent 10 days there on aspirin and bed rest and probably a beta blocker, and was discharged and told to stay off work for 2 to 3 months, and then participate in cardiac rehab at the Toronto Rehab Center every week, twice a week for 6 months, driving 90 minutes each day that he went for that period of time. Now, today, that is not what a patient would experience. Today, that same 49-year-old patient who was admitted, who developed chest pain, would call 911. Paramedics would arrive at his door within 10 to 15 minutes, hopefully. They would do an EKG on site if he had typical pain. If he had an infarction, he'd be transferred in our region to Centenary, have a site, have an angiogram done, and have a stent placed typically in 90 to 60 minutes. His average hospitalization would be 3 to 4 days. He would start cardiac rehabilitation somewhere within 30 minutes of home within 2 to 4 weeks, and he would be back at work typically in 1 to 2 months at the outside. I'm on 6 to 7 medications for secondary prevention. So you can see in this 20 years how both the type of care we offer has changed and how what the rehab services we developed in our region impact patients so positively. I don't want to spend a lot of time in history, but I'd like to just give you a brief oversight of what amounts to 30 years of leadership and commitment in our region, because this is an important story. It demonstrates the value of community. It demonstrates how passionate members of our community, when they interact with us as physicians and healthcare workers and hospitals, can make real change. And it speaks to the kind of leadership that what was the cardiac care program for the Central East LHIN, the value of that leadership. This program that we're talking about started when a patient, that first scenario I presented to you, after attending Toronto Rehab for 6 months, wrote a letter to the then Vice President, Jocelyn Sikorsky, and said, if we're supposed to be a future cardiac center, why is it that I had to drive nearly 2 hours a week to participate in cardiac rehabilitation at a service outside of our region? And this isn't available closer to home. The response to that letter was that there was a meeting held with myself, Jocelyn Sikorsky, and multiple other peoples, and our strategic plan that year identified that cardiovascular rehabilitation should be a priority. And to the credit of our community, which Phil Diamond organized, and volunteers and donors who, particularly the Labreco family, who donated nearly $200,000 in that first year to build the rehab center that now exists in the 11th floor. We started the cardiovascular rehabilitation planning within a year, and by 1997, the Central East Regional Cardiovascular Rehabilitation Program opened on the 11th floor of Centenary. And although it sounds amazing, we served 180 people in that first year. Compared to where we are now. So now, 3 decades later, the Central East Cardiovascular Rehabilitation Program is actually the largest service in Canada. It's the only region-wide program by design in Canada and perhaps North America. We serve the Central East region from Scarborough through Durham, Northumberland, Kawartha Lakes, out as far east as Bowmanville and as far north as Bobcaygeon at more than 18 sites. And currently, about nearly 4,000 patients per year participate in cardiovascular rehabilitation. This is, in my opinion, although we were the first center with EPS and PCI and angiography, this is actually our greatest achievement in the sense that no other center has done this, and we should be proud of the fact that this is the largest cardiovascular rehabilitation center in Canada. And I'm going to show you that our results in terms of benefits to our patients improve population health dramatically. So how did this occur? Well, firstly, there was community advocacy from Phil Diamond and the Labreco family that brought this to the attention of the hospital and supported people like us and myself to ensure that this was part of our strategic planning. We had support from Terry Cavan on the Toronto Rehab Center to advance this process and build this kind of service in the East. And Terry Cavanaugh, who is effectively the father of cardiac rehabilitation in Canada, became a colleague and friend and strong supporter of the initiative over that subsequent period of time. The leadership here and with outside colleagues, including Neville Susskind and Sean Goodman and multiple others, worked to form an organization called the CRNO, who advocated for expansion of this program as a regional program and worked with the province to develop guidelines and expert panel that ultimately led to the recommendation that this kind of program should exist. And to the credit of the Ministry of Health, an expert panel was held, and in 2000, a pilot study was conducted that demonstrated that this vision and this model was actually effective and feasible, and recommended this be adopted as a regional program. Now, sadly, political winds changed and that didn't happen. But our region, with the leadership of the Central East LHIN, including Trixie, who is our medical director and sadly is leaving, Glenn Boatswain, James Malash, and the members of the LHIN accepted the notion that this was high value to our community and funded our growth to allow us to become the service we are. And in 2017, that same group of people, including Neville Suskin, a close colleague and collaborator, came together to form what we have been for the last 6 years, was a research-driven organization with a dedicated cardiac research outcome group that has published widely now, and I'm going to share with you. So this is where it started. We began cardiac rehabilitation in 1990. The ministry did this pilot in 2020 that demonstrated that a regional approach to cardiac rehabilitation as an integrated strategy was effective, could be coordinated, and would meet the needs of the province of Ontario. And it was estimated that it could lead to substantial savings for the Ministry of Health. As I mentioned, sadly, this didn't occur, but our LHIN, with leadership from our cardiac care program and a commitment that this direction was proven and appropriate, accepted that we should transform our program into a region-wide delivery model, serving not just Scarborough and West Durham, but a broader community, using what we learned from the rehabilitation pilot project. And that's how we got to where we are today. So let me talk a little bit about where we are today, like what the service is and why it's so important. So firstly, the definition of cardiovascular rehabilitation that was been in place in Ontario for 30 years and initially put to pen by the expert panel in 1999 is a good summary. It states that cardiovascular rehabilitation is an integrated multifactorial intervention or service that is designed to enhance and maintain the physical and psychological and occupational status of individuals who have established vascular disease or who are at high risk of future development of vascular disease. So I'd like to be clear that it closes by saying that the purpose of this is to prevent progression and recurrence. And I'd also like to be clear that they didn't say establish cardiac disease, they said vascular disease, which was very important to our early thinking. And I'd like to leave you with the notion it's very important to our patients. So on that note, the question is, well, who benefits from cardiovascular rehabilitation? Who should participate? Any patient with established ASCV or arteriosclerotic vascular disease at any site should participate. So that is any patient with heart attack or coronary disease, non-disabling stroke or TIA, peripheral vascular disease, renal vascular disease, heart failure regardless of the cause, or people at very high short-term risk, like diabetics with multiple risk factors over the age of 55, who de facto probably all have coronary disease, they just haven't had it fully detected yet. The reason it's rehab is appropriate for all these individuals is they all have the same risk. They all have the same underlying process, which is either heart failure or arteriosclerotic vascular disease. And I'm going to show you we have evidence for their benefit. So if one of your patients has any of these established conditions, as our current referral form shows, then they should be referred for cardiovascular rehabilitation because of the impact it can have on the health, and they're all candidates. When they're screened by our team, if they meet the criteria, they are candidates and will join the service in the way we'll talk about. If someone is a candidate for cardiovascular rehabilitation, they participate in a workflow which is consistent with the Canadian Ontario rehabilitation guidelines and which has been proven to improve outcomes. It is a combination of patient self-management strategies that is designed not to do what I do in my office with the patients or their family doctor does or you do, but to provide lifestyle coaching with education and supervised exercise to train them to be able to, on their own, continue the recommendations you've made for secondary prevention, supported by a healthy lifestyle and with much better knowledge. And it's this that supplements what you and all of us may do when we prescribe medications or give advice about lifestyle. That those prescriptions and that advice and those diagnoses are high value. But patients need support to learn how to follow our advice, and cardiac rehabilitation provides that intensely and very well. So if you make a referral, what happens to that patient? Well, the other novel thing we did in our region is that we standardized the referral form as a single referral form that is now in Ocean and on paper the same right across our region. Those referral forms go to a central coordinating center where they're accepted and reviewed, and if the patient's accepted, they are scheduled to attend cardiac rehabilitation in one of the community centers in our region that are closest to where they live or work. And then our regional workforce goes to those community centers and delivers care. So I'll leave it with you. This is not a medical service. There's no doctors involved. It's not a hospital service, because other than the Centenary site, which is the only site in our region that is a hospital-based service site, and it really functions as a non-hospital service. Then it's on that basis they're placed in a community center close to home, and then they're supported by our staff and a dedicated health information system that Neville Susskind developed that we've used for 20 years. This is just to show you that our central referral site, acceptance site, is a group of dedicated trained staff who receive referrals by whatever way they come in, EMR, Ocean, fax, phone call, review the criteria, accept the patient, and if a candidate, initiate their journey in cardiovascular rehabilitation seamlessly and quickly. Patients then participate in cardiovascular rehabilitation in one of now 18 sites across the region. You might ask, well, why these 18 sites? So we use simple measures through software that allows us to determine travel distance, and found a series of community centers with full support for our municipalities and mayors that were all situated in practical locations that for the larger part of their community are less than a 30-minute travel time. We're proud of the fact that right now, 95% of the people who participate drive less than 30 minutes from a service. Our regional workforce, which is large and well-trained, are all dedicated cardiovascular rehabilitation specialists. They're not working part-time in our service and commandeered based on other skills. All of these dedicated people work from a common workflow, which is consistent across the region, and deliver the same high-quality care everywhere. We live by the mandate that every patient participating at any site should expect the same type and quality of care, which we, I believe, with the support of our management through Glenn, Trixie, Adam, and all of our staff, deliver. People have asked, well, what does cardiac rehab do? I'm not going to spend a lot of time going over papers, but I'd like to summarize quickly what we know in the broadest terms about the benefits of cardiac rehab, the therapies we provide, and exercise. So in combination with everything else the physicians do, we have clear evidence that regular exercise benefits patients by increasing blood flow. It promotes collaterals. It opens areas of muscle and organs that in lower levels of blood flow with less exercise are less likely to have as good a blood flow, and it appears to reduce the likelihood through those high flow conditions of future arteriosclerotic vascular disease. We have pretty good evidence that exercise, and this is clearly confounded by other things, including therapies and other components of people's prevention, does reduce arteriosclerotic vascular burden. And we have clear evidence with exercise and lipids of regression. While exercise is just a part of that, it is an important part. It's been known for 30 or more years that exercise lowers blood pressure, and cardiovascular rehabilitation does that. Now, patients in cardiovascular rehabilitation, seeing family physicians, healthcare providers, and doing all the other things prescribed, also have input about their blood pressure therapies that concomitantly reduce blood pressure. All of this is positive. The net result is that we have good evidence that exercise is protective with regards to general health and probably in relation to every system in our body, so that while we may argue about the mechanism, there is ample evidence to suggest that all these things happen, and I'm going to show you evidence that the outcomes are significant. So we Our program, and cardiac rehabilitation in particular, has been very committed to the notion of research to confirm population health and guide what we do. And it has had a significant impact on how we develop this service. In 2017, myself and Neville Suskin, with assistance of Adam and Thiru, our data analyst at the Cardiac Care Program, initiated a cardiac rehabilitation population outcome research group. We had strong support from the University of Western Ontario, including Neville Suskin, who's a professor and ISIS scientist in cardiology at Western, Stephanie Frisbee, who's a professor of epidemiology, and Severio Stranges, who's the professor and chief of epidemiology at Western Hospital, to begin a process to evaluate and publish related to outcomes. And in this time period from when we formed 8 years ago, we've actually published 24 abstracts and have 2 papers in press, which I'm going to highlight for you. So what have we shown? I will show you now that we have shown that cardiovascular rehabilitation in the Central East region, delivered the way we do, compared to controls in the rest of Ontario, reduces cardiac events. It reduces mortality. It reduces hospitalizations, emergency visits. It reduces length of stay if you are admitted to hospital. And at the same time, it appears to increase visit frequency with cardiologists and family physician, suggesting that there's better engagement by people participating in cardiovascular rehabilitation. And we deliver this because there's no medical component, no longer any testing, at a low cost, currently now of less than $1,000 per patient for 24 visits for 6 months. If you compare that to a day, and that's less than a day in hospital, it's about the same price as a consult with an echo and an EKG. And I'm going to show you that expenditure over 24 months leads to the outcomes that I described and saves the healthcare system a significant amount of money. So this is the data we published at the American Heart Association, and after performing a ARQ, Advanced Quality Research Evaluation, with ISIS and the Ministry of Health. What we did was we compared 1,300 matched controls by propensity matching to patients outside of our region who didn't have access to the same level of cardiovascular rehabilitation, but who were matched for things like age, sex, admission to hospital, diagnoses. And we showed that the mortality was reduced significantly in this cohort in the 5 years of this in retrospective propensity analysis. We also showed that hospital admissions were reduced significantly, and if people were admitted, their length of stay was lower. This was matched by a similar reduction in hospitalization, and what pleased us the most was that it appeared not to be associated with the typical barriers that block participation in cardiovascular rehabilitation. Historically, patients who've been referred to cardiovascular rehabilitation under participate, don't complete the program or don't start based on gender and socioeconomic status, with women and people in the lowest socioeconomic status groups typically not accepting referral or not completing if they start. In our population, the gender and socioeconomic barriers appeared to be abolished, with no significant difference between male or female participation. We can't ask people their income, but when we stratified people by postal code, which is tied to income, there was little or no discordance across all the socioeconomic statuses by postal code. Pretty strong evidence that by providing the service close to home, the barriers that people experience related to age, gender, and other things appear to be reduced. I haven't got the age-related data here, but it showed that age was not a factor until you get to the advanced parts of age, which we think reflects mobility. I mentioned cost. Previously, David Alter at Toronto Rehab Institute had published data that cardiovascular rehabilitation reduced costs of the healthcare system by $2,000 per patient participant. We went into this evaluation wishing to confirm that, and here's what our data show. We first confirmed through Adam and Thiru's excellent work what our cost structures were. And as you can see, more than 80% of our costs go to delivery of care at sites for patients who are receiving cardiovascular rehabilitation. And our administration, management, IT, and other costs are low, below 20% of our total costs, including equipment. And in this period of time since the study was published, equipment admin costs have fallen, if anything, because we, as I said, don't do stress testing and de-emphasize that. We did a propensity match study comparing our population of patients to match populations in the province, like we did for the other data I showed you, and compared using the ICES database actual health system utilization costs for all the boxes shown here: medication, community services, long-term care, procedures, and admission, and showed that in the first 3 years, any participant in cardiovascular rehabilitation had about $5,680 less costs attributable to their care than someone who didn't participate in cardiovascular rehabilitation, with an added cost of cardiac rehabilitation of only $840 per patient. Most of that added cost, as I showed you in our outcome data, was related to long-term care, meaning people became disabled or were admitted to hospital. This reduction in long-term care and admission rates, it reflected the saving. There may be other savings, and certainly there are quality of life gains that we didn't measure here, but this number is larger than has been reported before, and says that for every patient we refer with arteriosclerotic vascular disease who participates for that 6 months, in the next 3 years uses nearly $6,000 less in healthcare resources. So if that's the case, cardiovascular rehabilitation is not only cost effective, but it actually pays for itself in terms of the overall system costs. We don't manage the healthcare system that way, but we're strong advocates for the notion that all the things we do should be measured in terms of what they do to improve our patients' outcomes. So where are we going from here? Well, our strategic plan, which was recently published, had been discussed by our group extensively before the planning process began, and didn't change after the planning process. We wish to continue to expand this process. While we've done a good job, particularly with people who are admitted to hospital through automatic referral, we know there's a large number in community service being cared for out of hospital who should be referred, and we wish to expand that both in terms of community access and the full spectrum of ASCVD. To do that, we know we need to increase our capacity, which is now about 4,000 patients per million population per year. We'd like to increase that to about 5,000 per million. We believe if we do that, we can accommodate the non-disabled stroke patients, the complex diabetics, and the peripheral vascular disease patients, and improve their outcomes significantly. Through our team, we've begun a process to develop more culturally and linguistically and contextually appropriate patient resources, both in terms of the web resource we have and written patient materials we share with patients, because we believe that beyond distance, culture and gender are a barrier that we haven't addressed, but which we can address, and we will both do this and study this further. We believe we are a center of excellence in cardiovascular rehabilitation, but we want to grow our footprint publicly and from a research perspective into a formal center of cardiovascular rehabilitation, and hope that SHN and Lakeridge, with their university alignments, that this will be endorsed, and we will strengthen our relationship that's been very strong with the University of Western Ontario, and we can make stronger. And that, I hope, will lead to us being able to advocate provincially for our program, which has been very hard to do, and increase our research output. In the last few minutes, I'd like to leave time for questions, but I want to just come back to how patients enter our system. And I'd like it to be clear how any of us, yourself and all of us participating today, if we have a person who is a candidate for cardiovascular rehabilitation, how we initiate that and what that process looks like. So I mentioned to you, we have a standardized cardiovascular referral form that we modified over the years as a team to ensure that it reflects our goal, which is that every patient with ASCVD that's established has an opportunity to participate in cardiovascular rehabilitation with a limited amount of paperwork, so there are few or no barriers. So this form you see in front of you is pretty simple. It lists the main categories for which we have evidence that fall under those ASCVD brackets I talked about, plus heart failure. It it lists for our education and to support our knowledge transfer to the patients the risk factors, although that's not a criteria for participating unless you're in the high risk second prevention category with diabetes. But I think it's part of our engagement with our referring physician and patients. What happens when this form is received by our central booking office is that the patient is directly contacted. It's identified where they live and work, and with the patient, it's determined which of the sites is closest to where they live or work that they prefer to attend to. They are booked for their first intake session, typically after any other testing is completed, on average 4 to 6 weeks later, but as early as 2 to 4 weeks. And then they begin this 6-month journey weekly for 6 months. They graduate based on performance, not actually time. So some patients who are knowledgeable and get to targets and feel self-sufficient may graduate in less than 6 months, but the program is funded for the whole 6 months for all those who wish to and would benefit from participating. And that's all that's required. If, as I mentioned to you, where we can all help in this process is to increase the access and referral of patients who may be missing this valuable program now. Because we have automatic referral for ASCVD admissions, we don't miss many patients admitted to hospital ASCVD, and we're working with the neurology group and Dr. Smith to have the same process in place for stroke and TIAs who participated in any of the, either through admission, through any of the specialty service SHN. We're working with renal and vascular to ultimately bring the same degree of connection. But the population in the community, seeing physicians in the community, whether that's primary care or specialists, is actually substantially larger than that admitted population. And like I said to you before, we can do more good by catching patients earlier and getting them on this track earlier. So if there is one way that all of us can help to make our established rehabilitation service more effective and increase our population health more, it's by helping us to reach out to more of those patients. In fact, we even allow at this point patients who have established ASCVD to self-refer. They won't be accepted if we don't subsequently get evidence that they have ASCVD and they qualify. But our principle has always been that we'd like more referrals and properly triage them than less and have people miss out. For example, automatic referral leads to about more than half the referrals being rejected because they've already participated, or they're and they don't, or they're in it at the time and they don't need to re-participate. But that's okay, because it only takes us a minute to exclude those. And if at the same time, even one extra patient who would have been missed gets through our gateway, then we've done the population a favor. So I think leaving 10 or 12 minutes for questions, I'd like to end at that point. I have tried to keep this brief and focused on the values of the system. Our staff, Adam, who's the manager, and any of the rehab staff, some of whom are online today, are available anytime if you either want to call the 11th floor or pop up for a visit if you have questions or would like to see the service. As I said, it's delivered in community centers, but the 11th floor facility, which was built at the start of the program, is a purpose-built, remarkable facility, and we'd welcome anybody who wants to visit that. I don't see any questions in the chat box, but I'm more than happy to stay around for the next 10 minutes. And as I said, I'd welcome people unmuting their mic and asking questions if they have any. On behalf of the whole team, I'd like to thank you for allowing us to present today. I hope this has been valuable to you and helped you understand what we've tried to accomplish for our region over the last 30 years, which I believe has contributed great value to Scarborough Health Network and all of our partners across the region. So with that, if people have to leave, that's great. If you have questions, again, please unmute your mic, or I've got the chat box open. Please feel free to enter a chat question of any kind. If there are no questions, I'd like to thank everybody for participating. As I said, I hope this was useful for you, and I look forward to seeing more and more of our patients participate in this service going forward. Thanks very much, and I really appreciate the invitation today to highlight this for you. Thanks, everybody, and have a great week, and I hope a very good new year. Bye-bye.